Ladies and gentlemen, we thought we'll give you a mini didactic session, and I'm going to start by talking about the new oral anticoagulant drugs. And as you know, and I'm going to start by reminding you that unfractionated heparin had a double action, probably equal, an anti-10A action and an anti-2A action. Low molecular weight heparins came in, and they had mainly an anti-10A action. Fondaparinux has purely an anti-10A action. Now we have oral drugs, such as rivaroxaban and apixaban, that have pure anti-10A action, and dabigatran, which has pure antithrombin action. And I'd like you to remember that. And I'm going to go through the phase 3 trials, initially for the prevention of venous thromboembolism. And this is a slide I got from Dr. Turby that summarizes all the randomized controlled trials that have been done for total hip replacement and total knee replacement. And here we have the benefit, and here we have the bleeding. And we start with the beginning. We start with the dabigatran, and here we have the 2 trials on hip and the 2 trials on knee, and this is the overall effect. Here we have the rivaroxaban, and we have the 2 trials on hip, 2 trials on knee, and the combined effect. And here we have apixaban, and so on. What I'd like to start by telling you that in the case of dabigatran, there has been no difference when it was compared with enoxaparin. There was complete equivalence in terms of efficacy. And in terms of bleeding, again, there was absolutely no different harm between the enoxaparin and the dabigatran trial. Now, when we come to rivaroxaban, efficacy was in favor of rivaroxaban compared with enoxaparin in all the studies in hip and in all the studies on knee, and here is the end result. In terms of bleeding, there was a trend for increased bleeding. It was not quite statistically significant, and this bleeding increase was with enoxaparin. So it appears that there is less bleeding with rivaroxaban. And finally, we come to apixaban, and apixaban there was benefit in favor, more efficacy in favor of the drug, and no difference in bleeding. And really, that summarizes the studies that we have available. And as a result of these studies, rivaroxaban has been approved by the Canadian, American, FDA, European regulatory agencies for prophylaxis for total knee replacement and total hip replacement. And dabigatran has been approved by the European and Canadian regulatory agent for prophylaxis for both total hip and total knee replacement. But there has been a problem because a number of cases of fatal bleeding worldwide appeared, and in December, FDA initiated an intervention, an investigation into this serious bleeding, and we're waiting to hear of the results. So in our recommendations that are being written right now, we have said that for elective hip replacement, these guidelines will be published next year. Rivaroxaban, dabigatran are grade A, and for knee replacement, we said exactly the same. And of course, we put in brackets when approved for countries that have not yet been approved. And that summarizes what I have to say about prevention. I'll now come to the treatment of DVT, because there are many studies now on the treatment. Now, this slide summarizes all the randomized controlled trials, and I'll take you through it. Down here at the bottom, we have the 2 studies with apixaban. They're still ongoing, so I will not have data to report. Here we have the 3 studies on dabigatran. These 2 have been presented recently as abstracts, and I'll give you some data. This has been published, and now we have the phase 3 trials here with rivaroxaban, and they have all been published. So I will start by presenting the RECOVER study with dabigatran, and in this study, patients with symptomatic venous thromboembolism were randomized to standard anticoagulant therapy, parenteral followed by warfarin, or a parenteral for 5 days followed by dabigatran. And if you look at the cumulative risk of recurrent venous thromboembolism, there is absolutely no difference, and there is complete equivalence in terms of efficacy. Now, however, when you look at the major and any bleeds, you see if you look at here, any bleeding, you can see that with dabigatran we had less bleeding. When you look at major bleeding, there was absolutely no difference. I'm going to skip this slide. Now, here in this study, patients who had already treatment for the prevention of venous thromboembolism for 6 or 18 months with warfarin were randomized to continue with dabigatran or with placebo. And this went on for 6 months. And at the end of 6 months, recurrent venous thromboembolism was 0.4% with dabigatran and 5.6% with placebo, as you would expect. And this trial shows the benefit of continuing anticoagulation for a little bit longer with an oral drug. When you look at the clinically relevant bleeds, the incidence was 5.3% with the dabigatran and 1.8% in the placebo. There was no difference in cardiovascular events, and this difference was significant. Now, the conclusion when this was presented in Kyoto at the end of last year was that extended treatment with dabigatran was associated with a 92% relative risk reduction in recurrence of venous thromboembolism and a low risk for major bleeding. The other study that I will present is the patients who had long-term treatment, who had symptomatic venous thromboembolism. When they finished the 3 or 12 months of anticoagulation, they were randomized either to continue with dabigatran for 6 to 36 months or warfarin. And at the end of the study, the recurrence rate was very close, practically the same, so there was no inferiority. The major bleeds were increased with the warfarin, 1.8 versus 0.9, and any bleeds were also increased with warfarin. But something disturbing appeared, that acute coronary syndromes were increased in the patients on dabigatran, and my colleagues tell me there is an activation of the C-reactive system, but we're waiting for more data for that. Now, the conclusions were that dabigatran was as effective as warfarin, but dabigatran was associated with reduced risk of bleeding and an increased incidence of acute coronary events. We need to wait. Time will tell us. Now I'm coming to the Einstein DVT study. In this study, patients who had confirmed symptomatic DVT without pulmonary embolism were randomized to receive rivaroxaban, and this is very important, from the very beginning, an oral tablet from day 1, without any subcutaneous heparin, or enoxaparin followed by warfarin. And this went for 3, 6, or 12 months, depending what the physician wanted to do. And if you look at the data, there is a trend for rivaroxaban to be superior, but it isn't, because it overlaps the 1 hazard ratio. And this trend is driven by the fact that if you look at recurrent DVT, there were twice as many recurrent DVTs in the enoxaparin group